For everyone who I haven't met, hello, my name is Zach Berman. I'm a interventional radiologist at UC San Diego, and I particularly specialize in liver cancer. And so today I'll talk to you about two of my passions over the next 30 minutes or so. The first one is the evolving HCC landscape and kind of where interventional radiology fits into that. And then I'll specifically talk about liver tumor ablation as it applies to colorectal cancer because there's been a lot of really high level evidence over the past couple years in really establishing our role there. So, before we talk about HCC, where we are today, I just want to warn you, this is one of the few areas in interventional radiology we have high level evidence to really justify, support, and really establish our role in treating these patients. So please buckle up. There's going to be a lot of charts and graphs and numbers, and I'll intersperse cases in between too to kind of solidify that role home. So the first thing I'd like to show you is actually the very first publication that kind of looked at the treatment of liver cancer. And so this is the first paper looking at embolization for HCC. It was done in Japan in the 1970s. I think it was the mid-70s. And here you can see 120 cases embolized, mostly with gel foam, because that's all we really had at the time. But what I really want to highlight here is that if we look at the 1 year overall survival, only 44% of patients were alive at a year, right? So getting HCC in the very beginning was a death sentence. It was 50-50 whether you're going to even be alive at a year, and your chance of being alive at 3 years was only 15%. Keep that in mind as we kind of show these impressive numbers going forward. We've come a long way since then. So where we are today, the BCLC, or the Barcelona Clinic, is usually the most common staging system that a lot of people use to treat HCC. The advantages of the BCLC system is that not only does it incorporate tumor size, multiplicity, etc., but it also considers the performance status of the patient and the liver function. Most of our patients with HCC are kind of balancing two competing factors. The first one is the cancer and the cancer-related survival, but then also the chronic liver disease that they have. At least in the US, almost every single patient you treat is going to have cirrhosis. And that's going to be a kind of second competing factor that's going to limit overall survival. And I think you saw in the previous talk, kind of the major complication of cirrhosis is the portal hypertension, whether it be bleeding or ascites, etc., can really be in a factor. So you could have a 0.5 centimeter tumor, but if you have end-stage cirrhosis, it makes no sense to treat the tumor. The cirrhosis is going to be the ultimate conflicting condition. So this is a very complicated graph, and there's a lot of arrows and there's a lot of lines. And as radiologists, or at least future radiologists, we like to think in pictures. And so I developed this nice little graph that kind of converts the chart into a picture. So we'll kind of take it stage by stage. So stage 0 and stage A, I think in my mind, I kind of put them together. You have small tumors and then early stage tumors. We're talking solitary tumors. And the goal of a solitary tumor is we want to get to something that's curative intent. Curative intent means 5-year overall survival. And so here you can see ablation and resection are the most common utilized modalities. And if they can't have either of those, then we talk about transplantation. Why do we say resection or ablation? As you can see here, there have been 3 randomized controlled trials done in the early 2000s that compared radiofrequency ablation to surgical resection, and the 1- and 3-year overall survivals were about the same. And so this is kind of level 1 evidence. The chance of being alive in 3 years is about the same, whether you have radiofrequency ablation or surgical resection. If we look at those 3 trials, plus a 4th one, which was done since then, and we do a meta-analysis of those, you can see that the hazard ratio crosses 1. There is no survival benefit by having surgical resection. And a kind of ongoing theme that you're going to see over and over and over again as we talk about ablation is that the side effect profile, the complication rate or serious adverse event rate, significantly lower in ablation. And so a lot of our patients with small HCCs go for percutaneous ablation over surgical resection, mainly because of the side effect profile, and there's no difference in overall survival. This is just an example of what a microwave ablation looks like. You can see this patient had a surgical resection in the past. Right here, you can see the staple lines. You can see a microwave ablation probe going to the recurrence. Intraprocedurally, we can see the hypoattenuation afterwards. And more importantly, 6 years later, we don't see any residual tumor left. This is kind of the ideal scenario. We're going to continuously talk more and more and more as we go through time about histologically what happens on the cellular level. This is a beautiful study looking at 195 HCCs and 97 patients who were treated with stereotactic radiofrequency ablation. Stereotactic meaning image guidance, making sure your probe was in the correct place with a bunch of different guidance modalities. And they show that 97.3% of these had complete pathologic necrosis, meaning every single tumor cell on explant was dead because of the ablation. Nothing in life is ever 100%. And so I think 97.3% is amazing. So as tumors get larger, the chance of having a complete ablation gets harder. So there was a randomized controlled trial looking at TACE and radiofrequency ablation versus radiofrequency ablation alone. This is for tumors greater than 3 centimeters, so 3 to 5 centimeter range. And you can see here, not only is the progression-free survival prolonged in the TACE plus RFA group, but so is the overall survival. So if you start to have larger tumors, 3 to 5 centimeters in size, you can't just do radiofrequency ablation alone. You should think about maybe adding in TACE or consider additional modalities, which we'll talk about. Unfortunately, not every single patient is a good candidate for microwave ablation. Here you can see there's a tumor here at the hepatic dome. This was reviewed by our multidisciplinary tumor board, and they said this is not definitely an HCC. So before we treated it, we needed to do a biopsy. The only way we could do a biopsy, as you can see here, is we had to go all the way through the liver and take a biopsy that way. There's very little appetite to stick a much larger ablation probe all the way through the liver like this, or going through the lung in order to get to that area either. So, if it's not an ablation candidate, what options do we have? In this example, this is where I think radioembolization can be very helpful, which was a very difficult biopsy. We can see we can get a microcatheter very targeted right to the tumor, where we have really good dose escalation with modern dosimetry. The reason we can do that is that we're only treating 4% of the total liver. And we have good evidence to justify this. So this was a multi-center study looking at about 143 patients. And you can see on a waterfall plot, almost every single patient had a complete response. More importantly, 76% had a response at 6 months. And progression-free survival is 94% at 2 years. Again, we're doing one therapy and the patients are good for many, many, many years. And again, that's the goal. So when we look at the evidence of radioembolization compared to microwave ablation, you can see here, even though there's no randomized controlled trials, we have comparable 3-year overall survival rates. So the legacy was the study I showed you on the previous slide. There was another prospective study done called RAZOR. They only reported 2-year overall survival, but the 2-year overall survival was very similar to the microwave ablation. So where does TACE or SBRT kind of fit into this? So here are 2 randomized controlled trials. One was randomizing patients to either proton therapy or TACE, or photon therapies versus TACE. And you can see in both of these trials, the overall survival was indifferent between the TACE versus SBRT arms. But more importantly, if we were to compare TACE and SBRT to microwave ablation or radioembolization, at least in the American population, you can see that the overall survival is less. So at least in my practice, our first line is resection or percutaneous ablation. If percutaneous ablation is not an option for whatever reason, location, anesthesia, etc., we like to resort to radioembolization. Moving on from early stage disease to intermediate stage disease. Again, now we're talking about multifocal tumors. We're no longer talking about 5-year survival. We're talking about 2.5-year survival. And this is where we initially see a lot of the evidence for TACE. And this is an example of a TACE where you can see the dense all staining throughout the tumor. Where did the evidence come from? There were 2 randomized controlled trials done in the early 2000s that randomized patients to chemoembolization or best supportive care. Because again, that's all we had. We had no therapies for these patients. And so we just compared it to doing nothing essentially and just doing conservative symptom management. You can see the overall survival was beneficial for the chemoembolization group versus control, and you can see these were published in reputable journals. Therefore, chemoembolization became the standard of care, level 1 evidence. As we come to more modern times, we've now compared radioembolization to chemoembolization, and this is a pivotal trial called the TRACE trial, randomizing patients to either chemoembolization or radioembolization. It was actually powered for twice the number of patients that it ended up enrolling. It had to be terminated early because the survival benefit in the progression-free survival benefit was so much better in the radioembolization arm. It was deemed unethical to continue the trial. And so as you can see here, the survival was doubled from about 15 months to 30 months, and the time to progression also about doubled from about 9.5 to 17 months. As we're starting to realize with modern dosimetry, and as you guys are going to see as you keep going through, which I did not get at all trained in, this is how new it is, the idea of controlling how much dose goes to the tumor is becoming a much bigger deal. This is the Target study, which was a multi-center international trial looking at patients and stratifying them by different doses to tumors. So this is a Kaplan-Meier curve, which looks at survival percentage over time of months. And there's 3 different groups here, whether they had different dosimetry to different aspects of the tumor, less than 200, 200 to 300, and greater than 300. And you can see just by controlling how much radiation got to the tumor, we ended up with almost a 2-year overall survival benefit. So when I was in my training, you just kind of had a dose for everybody, and you just put that in there and you hoped for the best. We're starting to get better dosimetry, better computer programs, and better understanding of how this embolotherapy works, and we're getting better overall survival. And so if we look over time for patients who are going to get a liver transplantation, as we talked about previously, liver transplantation is the only thing that's curative for this kind of stuff. If you go back to the early 2000s to maybe around 2011 or so, you can see chemoembolization was king. About 70% of patients who had HCC were being bridged with chemoembolization. If we flash forward to today, that has actually changed. Radioembolization has now become the most common form of bridging therapy in the US, with thermal ablation staying about the same. So again, whoever was a candidate for thermal ablation gets thermal ablation. But for everyone else, we've kind of moved from chemoembolization to radioembolization, at least in the US. Moving from intermediate to advanced stage disease. Again, as we keep going further and further and the disease gets more advanced, tumor and vein metastatic disease, the overall survival decreases. So when we get to BCLC-C, so the advanced stage disease, we're kind of talking about the alphabet soup of all of these different types of systemic therapies, which we'll go through in a second. Why do we say systemic therapy and not our therapies? There were 2 big trials that were done, the SARA trial and the Survinib trial, both published in 2017, that showed that radioembolization was no different than sorafenib for having better overall survival. And so unfortunately, that's where it kind of languished for a while, with just sorafenib being the standard of care. However, in 2021, the Dososphere trial came out. Again, in both of the previous trials, there was just the same dose of radiation for everybody. In Dososphere, they actually said, well, what if we actually paid attention to how much dose the tumor is getting and specified a target dose for the tumor to optimize results? That's what they did in this trial. Again, only 60 patients were part of this trial. It was powered for well over 2 times this. Unfortunately, or fortunately, the results were so much better in the treatment arm, they had to stop it because it was unethical to continue. These were huge tumors, 10 centimeters, almost 2/3 of which had tumor in vein. And this is what the survival curves look like. You can see the survival went from about 10 months, which was very similar to the SARA and Survinib trial in the control arm. But if we look at the treatment arm, it's a 16-month improvement, over double, 2.5 times as improved to 27 months. Also, with our patients with tumor in vein, which is a very tricky tumor to treat, we got a 23-month overall survival, which is better than systemic therapy alone. So this is a very good population where I think we can really benefit our patients. So what about combination therapy? I think first phase 3 trial that was very intriguing for this was the LAUNCH trial. This was looking at lenvatinib, which is a tyrosine kinase inhibitor, compared to lenvatinib plus TACE. This is a randomized phase 3 trial. So again, level 1 evidence. This was done mostly in Asia. And more importantly, half of these patients had metastatic disease. So these were not necessarily patients we would ever see, right? Why does it make sense to treat a systemic disease locally? Again, a lot of these patients are going to die of their liver disease. So it makes sense that to control the systemic therapy with lenvatinib as systemic therapy, but then also boost the local therapy inside of the liver, you can improve overall survival. Level 1 evidence for that. However, since the advent of more systemic therapies, particularly immunotherapy, we have a lot of open questions. Do we do immunotherapy first, followed by embolotherapy? Embolotherapy first, followed by immunotherapy, or do we do them or do both of those at the same time? As we start doing more and more and more of these trials, you're going to start to hear all of these words, and then you're going to become facile with immunotherapy because a lot of patients will be on it. And I highly recommend if you're going to enter the space, you really understand all of these different types of therapies and the cells they act on and how they might interfere or your procedure might promote their use. And these are just all of the words that you're going to become used to saying: pembrolizumab, nivolumab, atezolizumab, durvalumab. Those all work on the PD-1, PD-L1, which you'll hear. But then there's ipilimumab and tremelimumab. Those work on anti-CTLA-4, which is a different receptor that involves instead of T cell, it involves an antigen-presenting cell. And all this other stuff that you thought you could forget after your first 2 years of medical school, it's all going to come back and you're going to need to know it. So what are the trials we have so far? There were two big trials that came out last month. The first one was Emerald 1, which was TACE plus or minus durvalumab plus or minus bevacizumab, and LEAP 12, TACE, pembrolizumab, and or lenvatinib. Both were global phase 3 multi-center trials, and both were positive. So the primary endpoint for both of these trials was progression-free survival. Here you can see the curve of durvalumab plus bevacizumab plus TACE versus just TACE alone. And you can see the progression-free survival was significantly improved. It was doubled. A very similar thing was seen in the LEAP 12 trial where it was lenvatinib and pembrolizumab plus TACE versus TACE alone. And you can see in a progression-free survival benefit of 4.6 months. Unfortunately, in this trial, the overall survival was not improved. You can see maybe a little bit of separation of curves. Hard to say, although the hazard ratio does cross 1 here. So at least as of right now, we can say we're making patients progress more slowly, but we're not definitively making them live longer. So we're still waiting for the survival benefit from Emerald 1. But as of right now, we have 2 level 1 evidence saying at least progression-free survival is improved. Where does radioembolization kind of fit into the space? There's 2 ongoing trials right now. One is called Rowan, which is durvalumab and tremelimumab plus Y90. That's about two-thirds-ish accrued, so we should hopefully have answers in the next year or two. And the other one is Emerald Y90, which is looking at durvalumab and bevacizumab plus radioembolization. That's about a quarter accrued. So we're still waiting for a few more trials or a few more patients before we'll have the results from that one. This combination therapy, at least in my practice, is becoming a much bigger part of who I'm treating. And again, as we were talking earlier about multidisciplinary clinics, it's super important if you have the chance to have a multidisciplinary clinic. It's really beneficial to be with your oncologist because a lot of these patients are going to be on complex regimens, and having the ability to be right there with the oncologist who's managing that is very helpful. So that's my little plug for that.